Hello, everyone. So today, as you all know that this is my best and my favorite podcast with, in my opinion, the best DMEK surgeon in worldwide, and one of the best friends that you can ever know in your life, Dr. Jack Parker. Let's say hello and cheer him up.
Well, hey, Hosny. It's always so nice to talk with you. I think these podcasts are super fun to do. You do a humongous amount of work always to put them together. I mean, really, it's amazing. I really just show up and it's your show. So thank you for inviting me to be on it.
Thank you very much, Dr. Jack. It's actually your show. I just coming actually to learn from your experience, and to be honest, more than that, I have fun and be happy always when I am just talking to you, Dr. Jack. So today, actually, we'll talk about something very interesting because we always talk about how to unfold the graft, but now we need to talk about who or what we are unfolding. So we'll talk a little bit more about the graft itself. But before we're talking about it, we just need to announce that happily, Dr. Jack and myself are going to be speakers in one of the oldest and the biggest conferences in the Middle East, which is the conference of the Egyptian Society of Ophthalmology. We will be having our talk on Thursday, 10:30 a.m. on Hall A, Hall As-Saraya 1, and this will be the Intercontinental City Stars in Nasr City. And Dr. Jack will talk about, he will be actually the key lecturer and of this symposium, and you'll be talking about the endemic nightmare, enter if you dare. So this is like kind of the theme. It's about the scary endemic surgeries and how he managed with this complication. And mine will be something like a basic about mastering the from scroll to success, mastering the unfolding for the DMEK graft. So you have to come, and we'll be happy to see you there all in Cairo. So, Dr. Jack,
Super exciting because, here in the States, we feel like, well, we have good surgeons and challenging cases. And then you go into some other country like Egypt, for example, and you realize, oh my God, these are the challenging cases. These are where the great surgeons are. So
yeah,
I'm sure that it's going to be a very enriching learning experience for me to see the kind of pathology and brilliant innovations made by some of our colleagues, So I really can't wait to learn and see what I should be doing differently.
definitely, Dr. Jack. I think they are very happy and excited as well to see you there. And we have like some good or great surgeons as well will be joining in the symposium. For example, Dr. Ismail, Dr. Mahmoud Ismail, Dr. Tamer Rakal, Dr. Tariq Katamish, and others who are great as well. So I think all are happy that you are coming to Cairo, and we'll spend a very great time there. So let's go back for our own topic today. So my question, Dr. Jack, do you think always the difficulty for the demic surgeon is a surgeon related, like, or a graft related?
I think that when I have had trouble with DMEK graft unfolding, it's often not because of the patient. It's not because of the graft. I think it's because of the mismatch between the graft and the patient. It's that there are good grafts for some eyes, and there are eyes in which that same graft is not a good fit. And that's something that I think we'll probably spend some time talking about, but it is important to try to set yourself up for success. There is this writer, a former Navy SEAL, who is a popular author and kind of semi-celebrity figure in the United States named David Goggins. And he wrote this book about his experience in the military and as a Navy SEAL. And one thing he says is that it's very important the Navy SEALs instill upon you the idea that you never ever want to fight fair, okay? You always want to have some unfair advantage, which gives you a leg up. You don't want to be competing on an even playing field. You want to stack the deck in your favor. And when you're doing DMEK, I think it's very often important that you try to stack the deck in your favor by picking a graft that matches the conditions of the recipient eye. Can you put any graft in any eye and succeed? Yes, but why make the surgery more challenging than it has to be? You don't get points for doing the surgery in a more challenging way. You get points for doing challenging eyes that otherwise couldn't be done, but not by making it gratuitously hard on yourself. So I like to try to pick the grafts that match the patient conditions.
Yes. So, yeah, I agree completely. It's a mixture between the patient, surgeon, and the graft itself. And is the right decision is to match right as you are saying between them. But still, if we go for the graft part that we need to focus on today, so there is three different stuff in the graft. Maybe we choose the graft upon, or like we usually like used to do this before, is the age of the patient, the cell count, and the size. So in general, it was saying before. Do you think that really the young patient, the young donors, is a premium graft because they have more cells, for example, and more fresh, or what do you think?
Lots of patients think this, and I used to think this. When I was doing DMEK initially, I thought, well, it must be the case that young donor tissue is somehow better. That must be true. I would want a donor who's 20 or 30 years old, someone lively and young and healthy, not an 80-year-old graft. I want somebody young. And initially I thought, well, the reason people don't pick those eyes for donor tissue, it's because the surgery is too technically challenging, because the graft scrolls up too tightly and it's too difficult to unfold the graft and the surgery is too hard. So you have these surgeons out there avoiding the best tissue because they're not skilled enough to work with it. So I used to think, I'm going to be the one. I'm going to learn how to unfold really young, tight donor rolls, and my patients will have the best outcomes. And I ended up with the exact opposite results, okay? Because not only was the surgery needlessly challenging for me, but the real problem was that these young donor grafts have higher detachment rates. And
Okay.
the reason they have higher detachment rates is because the elastic tendency of the tissue is greater. So the tissue wants to curl back up on itself. It wants to coil away from the back surface of the recipient cornea. And it's not just that the detachment rate is higher, but the chances of successful rebubbling are lower, because if you have a detachment that's a flat detachment and the graft is just flopped off the back surface of the cornea, very often you can come up underneath it and lift it up with an air bubble and press the graft back up against the recipient corneal surface. However, if you have a really tight donor graft, sometimes the graft is rolled up. It's a curl. And if you just lift it up with an air bubble, you're just smashing that curled tissue up against the back surface of the cornea. That's not going to fix it. Rebubbling a curled up edge won't fix it. So the young donors are more likely to detach and they're more likely to fail rebubblings. And just like pretty much everything that I know, I learned it all from Garrett, because if you look back at his data about DMEK from 15 years ago, his data reported that older donor tissue have lower rebubbling rates. So this is not my discovery. Garrett figured this out 15 years ago, and people just haven't fully recognized the importance of all of the things that he discovered. So I think this is interesting because it's very counterintuitive. You would think you should use young donor tissue, okay? But it seems like everybody who's really looked at it, including Garrett Mellis, concludes that the opposite of what you would think is right. Use older donor tissue.
Okay, so what happened that I was having this trouble that I used to have a case for like it's a deep anterior chamber vitrectomized eye and anterior chamber IOL with multiple failed DZECs. So I say, okay, like I will start to do DMEK because I'm quite sure from what I have learned in Parker Cornea that DMEK is number one now in this kind of cases. So I started to do the surgery. I want to show a small video now about the surgery to learn from you as well what should have been done in this surgery so that we don't have the sorry, this is not the video, sorry. One second. Okay. Yes. So first of all, as you can see, it's a very tough and thick, like DMEK graft. We have to take it very big adhesions and stuff, and I have to clean a little bit as well the rest of membrane. Now it's better view. See this big gap here. I was very afraid to do any jets of water, otherwise it can get inside. So I was happy with the configuration at the beginning, but unfortunately, when I did the Matsuru sign, it was upside down. I was actually keen at the beginning to do it a double roll, but that was happened. I tried all the maneuvers that I can do, but I find this very a strange thing that the graft was always being stuck in this area, and I don't know till now why. And this is maybe the area above the big epithelial defect. After a lot of maneuvers, it opened a little bit to a more friendly shape here. But as you can see, after a lot of wearing off of the dye as well, I put a bubble. So because I say, okay, I will try to open it with a bubble. I put a bubble underneath as well, so that I was all the surgery afraid that it can fall down from this. I take this bubble underneath, and this is the bubble below. I try to tap it all the time. It doesn't want to move really from this corner. Even I let the patient look down as here. Still, it didn't work. Um, After that, I started to maybe put a bubble underneath again and start to do any taps. Here is it's folded here. The one that you say the rolled, it was rolled, and I just remove the bubble, try to unroll it, but unfortunately, it was a little bit decentered, like it's just on the edge of the pupil. I say, okay, I will not maneuver more than that, and I will put a bubble and happy days, even if I am not the most satisfied surgeon at this day. But I say, okay, it's better than fizzling more than that. So, first of all, what you have done more than I have did to unscroll it, this very tight. By the way, this patient is 49 years old, the donor, with
Wow.
all this thing. So, what do you think? What you could have done, and why you think the graft was stuck in this area, which is probably above this gap in the iris?
Can we play the video again? Can we
Sure,
play the video again? Is that possible? And then if I tell you to stop, maybe we can stop and discuss things.
sure.
Okay, so
I will get.
this first of all, congratulations on taking up such a challenging case. Obviously, very, very challenging case. And
Yes,
let's get to graft injection and then get ready to pause. Okay,
yes.
pause. Pause.
Paul. Okay.
Okay. So when I look down at this tissue, I notice a few things. Okay.
Yes.
First of all, it's a great size. Maybe this looks more than 8.5 millimeters, 8.759. Is that how big is this graft? Do you
Yeah,
remember?
it was 8 or 8.25.
825. Okay.
Yeah,
It looks the right size for this eye. I mean,
yes.
certainly if you're working in a unicameral eye, particularly with a tight scroll, you want a large graft because if you have some little graft spinning around in the depths of the anterior chamber centrally, it's so difficult to pry the graft open. So you really want help by using a big graft that stretches out into the angle where it interacts with where the chamber is shallow, and that really helps you prop the graft open. So this looks like the right size tissue. I think that's really good. Now, um, when I look at this graft here, The way that I typically proceed with my DMEK surgeries is opportunistically, rather than thinking like, okay, this is my go-to unfolding strategy. I look at what the graft shows at any one point, and I think, how can I capitalize on what happens to be before me? So when I look down at this graft right here, it seems like it's upside down. And the way that you can tell that even at this stage is if you look at the edge of the tissue down inferiorly, away from where the iridotomy is, if you look at the edge of the graft, it's kind of blunted. You can sort of tell you're looking through tissue to see that edge.
Yeah.
So you can tell already that this graft is going to be upside down, okay? So what you want to do is flip this graft over. How to flip this graft over? Well, there are generally two strategies. One that I employ most of the time, and one that I would employ in this situation. The most of the time situation is when you have a graft that's upside down, you want to squirt perpendicular to the lie of the graft. So that would be using one of these paracenteses. You would burp that wound while you irrigated to flip the graft over and around. That works well for normal eyes with a normal anterior chamber, okay? In these eyes, though, where you have a tight roll and a hyper deep chamber, if you irrigate and burp, there's no guarantee the graft isn't going to just curl up on itself and just be floating in the depths of this giant chamber. So what I would do in this situation right away is I would go in through a paracentesis, probably the one on the left, the superior paracentesis. And I say that not because I want to use my left hand, I'm a left-handed surgeon. I say that because the goal would be to use coaxial forceps through that superior paracentesis and grab the edge of that graft, which is down. And if you grab and pull, if you grab that edge and pull, that will flip the graft right side up manually. And it'll be nice because you'll have control over the tissue. So what I would do here right away is I would identify this graft is upside down. I would reach in with forceps. I would grab the edge of the graft that I can see. You know, the other edge, the way it's curled, I can't really see it. It'd be tough to grab, but I can see that edge. I would reach in, I would grab it, I would pull superior while putting taps on the surface of the cornea. That technique is called the pin and roll, and it's how you flip a graft in a hyper deep chamber. Grab the edge and pull while placing taps on the corneal surface, and that'll flip things over. So right away, if you just identify this pattern, that's how you can solve this unfolding configuration. Keep going. Let it roll a little bit more, and let's watch a little bit more. Okay, so here, stop if you will. Okay, do you notice how the eye is sunken and collapsed right now?
Yes.
The way you can tell that is because the cornea is sort of concave with those stria in it.
Yeah.
Okay. The reason that you see this is because you're manipulating the graft through the main wound, just like I taught you. Okay. Just like I taught you. But in this one situation, in this one case, you have to be careful about that. And let me tell you why. This is an eye that's basically unicameral because it's post-vitrectomy with an ACIOL. And when you have a situation like that, it's so much easier to decompress not just the anterior chamber, but the entire eyeball by going through the main wound. If you're trying to manipulate the graft through the main wound, the whole eye can shrink into this raisin and collapse, and you lose the normal structure of the eye, and then none of your manipulations work. So in these unicameral eyes specifically, I often try to do my manipulations through a paracentesis to avoid over burping the wound and losing not the graft, but losing so much fluid that the eye is so sunken in, you can't see what you're doing. So that's kind of the next point. Okay, continue. Okay, here I like this. You're checking the Motsuro sign and you can pause. Okay. So at this point, what I would do is a few things. Um, at this point, there's an air bubble interacting with the graft. I would probably remove that bubble again through a paracentesis here, just so it doesn't compete with any manipulations with the tissue. You really want you to be the master, not you struggling against some other thing influencing the graft's position inside the eye. So I would probably remove that little bubble. And at this point, you've checked the Motsuro sign, and this is right side up. Is that right, Hosny?
Yeah, but it
No,
scrolls
no.
after that.
Say again?
Yeah, so when I just was about to just check the Matsuru san, just I didn't check. Oh, it scrolls again.
Yeah,
It
yeah,
just
yeah, yeah,
become like a proper 49 years old graft.
yeah,
So yeah,
yeah.
unfortunately, I stay like this in this position for a long time trying to open. So that's only that the small window when the graft was opening. Then it take me a lot of time till I find a friendly position that I can deal with the bubbles. But
Yeah.
it kept like that for a long time.
Yeah. So when you have a sort of a single roll like this, especially in a deep chamber, and you're thinking, how can I open this graft? What I often do is one of two things. The most successful thing, in my opinion, is to irrigate down the barrel of the single roll from a paracentesis. When the graft is aligned with a paracentesis, irrigate down the barrel, and that will often flutter these edges apart. Or if you get really desperate, you can put an air bubble in. The air bubble works every time. The problem with using an air bubble down the lumen of the roll is that almost always what ends up happening is the way that the bubble catches inside the roll is the bubble expands and breaks the roll open like this, but it's doing that because the edges of the graft are down. So the bubble almost always opens the graft from the inside out upside down. It's almost always upside down if you open it from the inside out using an air bubble. So you can do that if you're desperate, but usually I prefer to use fluid.
Yeah. So what I can do, like I don't know if you can describe this feeling that I have. I was very cautious or very worried to do a lot of jets because this graft, as you can see, it was all the time for some reason stuck here. I tried even to come from the paracentesis to put some fluid, inject some fluid to get into the roll and put some fluid, but it was beyond. It was in the angle here. I
It's
tried
stuck at
to
the
move it.
temporal angle. Yeah.
Yes, it's just like just I see it under the angle here.
Yeah.
So
You have to directly engage with the cannula and push or grab
and
with
push it.
forceps and pull. People are
Okay.
so averse to doing that, and I understand why. I understand the natural emotional fear you have of touching that precious donor tissue,
Yes.
but you have to do whatever it takes to open the graft. It
Yeah.
doesn't help the patient at all if the cells are perfect and pristine and not on the back of the cornea. You've got
Yeah.
to get them on the back of the cornea any way necessary.
Yeah, that's right. So if you want me to continue here,
Yeah,
so
please.
I keep trying to move it away from this angle all the time. Um, I don't know. Actually, you think why, Dr. Jack? It was is something related to this big gap in the iris, like pulling. There's a force like pulling here, because like I tried everything. To be honest, the only thing that I wanted to try at the end to give strong jets, but I was kind of very worried if I get a strong jet, it just I lose the graft through this. So
You probably wouldn't. Probably not. Not definitely, but
yeah,
probably not. But the key thing is in these unicameral eyes, you cannot shallow the chamber. You just can't. And if you
yeah,
can't shallow the chamber, then taps on the corneal surface don't work. Taps
yeah,
on the corneal surface don't work if the chamber is not shallow. So
yes,
what do you do? How do you open a graft if taps on the surface won't work? Well, the only two choices that I know about are jets of fluid and air bubbles. That's it.
yeah,
That's the only two choices. Okay.
yeah,
And
yeah,
then maybe using the forceps to assist you using jets of fluid or air bubbles. And here, as the picture is frozen right there, the lumen of the graft is perfectly lined up through that left-sided paracentesis. So it's just begging you to irrigate down the barrel of that to try to break the graft open from the inside.
Okay, so yeah, I think I should have done that, but like if it's stuck in the angle, is there is any like any maneuver to push it if it's stuck in the angle? Like I can push it physically with something, like with
Yeah, just
the
with the cannula, just directly engage and push it off to the
and
side.
push
But
it.
taps on the
Yeah.
surface won't get it out of there. In fact,
Okay.
because taps on the surface, they compress, they kind of squeeze the graft more into the angle almost.
Yeah, yeah. That was actually that's what was happening. To be honest, like it was squeezing
Yeah.
more into the angle. So yeah, and this how the end happened. Just double scroll up here. I was just breathing now that there's something I can deal with. I put the bubble. Um, but that was long time anyway. Like see, even the graft, it took a long time. Have been the dye have been weared off.
That was the
So
right
I
move. Right there, putting the bubble underneath the graft, that's definitely right. And at this point, this
yeah
is really winning. If you go in with forceps and grab the graft and drag it over,
yeah
it'll be supported by that bubble. The bubble will keep it up there and you can pull it over and then tap on the edges and those folds would come out.
I actually that's what I was thinking of. Like I remember you like one of your videos was, or maybe I was seeing you, maybe I was doing a surgery. You did that, but because it was a long surgery, but that's I think was the choice. It's my mistake. I should have done this, but the thing that it was a very long surgery, and I haven't always asked about the forceps in my setup or even standby. So I know that it will take a long while till I get a forceps. So I
Yeah.
won't just remember when you told me just finish quickly, Hosni.
Yeah. Well,
Like
it's actually we've talked about it a million times, and I think
yeah,
this is the situation. You get to where you're working on the eye for an hour, and you
yeah,
just don't have it in you to spend another 10 minutes. I
yes,
mean, you just are mentally exhausted. You're emotionally exhausted from the operation. The patient, if they're awake, they're exhausted from the surgery, and it goes to show that you really don't want to rush with
yep,
surgery,
yep.
but the best way is usually the fastest way. If you can do something quick, if you can reach in, grab the graft and drag it over and be done, it's better than trying to do a no touch technique for 20 minutes or something.
Yeah, that's I agree completely. But yeah, that's how it works after and after few tapping. Even I just think maybe the position, if I let the patient look down, it might help. But it just stuck here in the angle for some reason. I tried. Yeah, I think the only thing in this situation was to get some microforceps from here
Yeah.
and see this is like a little bit unfolded. So it become like okay, this is not too bad. It's covering the pupil. And by the way, the patient vision after the surgery is getting better anyway, and she's happy with the
Great.
vision. Yeah,
Super. Wonderful.
yeah. So yeah,
Wonderful. Well,
that's
it's a
so
really challenging case. And it's a great video. Thank you so much for sharing it.
yeah,
I mean, I
yeah,
think
yeah.
that
Thank you very much, Doctor Jack.
very
I
few
just
people do DMEK in this case, and that's super nice. That's really
that thank you
impressive.
very much. I was always thinking about you when I'm doing this. Like you come here like in front of me and say, "Get a forceps hospital." It's like kind of no, like you're always in my mind when I'm doing this kind of stuff. Yeah.
Well,
So
it's just it's I watched that video and I just remember so vividly myself with those cases. I mean, it
yeah.
just I can taste that surgery, I mean, I identify with you so much doing that operation and I just remember like these moments of joy in my life where I realized like, "Oh, if I do this, that horrible feeling will stop happening to me." So
Yes.
you may just try it because it made me much happier doing some of those things.
Yes, I agree. It just sometimes when you do the normal like one and just the graft is centered and happy, and that's not the feeling. Like one surgery like this is like 10 surgeries, like straightforward surgery, because this is how, like as they say, the I don't know what exactly the quote is, but like kind of like an angry ocean just make a big a good sailor, something like this.
Yeah,
Like
right,
it's water
right.
doesn't make a good sailor, yeah.
Yeah,
But
right,
thank you very
exactly.
much, and thank you that like all your tips came to my mind when I was doing this thing. There is some people were saying about the pre-prepared graft. If we go for this part about the detachment rate, have you have an idea about this? They say if you prepare the graft freshly, it get a lower detachment rate than if it's pre-prepared. Is there, you find something like this in your practice, or
It may be true. I don't know. There are a few reasons why I don't know. Um, the first is that it takes so long to prepare a DMEK graft well. You know, it takes a lot of skill to do that. And if we're doing 20 DMEKs in a day, I don't have the time to do it. So even if the detachment rate is higher, when someone else prepares the graft and sends them to me, that's still what I would have to do because we don't have any choice. I just don't have time to do it myself. We're spoiled in the States. You prepare the graft yourself, Hosny. Your
yeah,
detachment rate may be less than me, okay? Maybe
yeah,
much less because
yeah,
it might be really better to prepare it fresh. That's the first reason I don't know. It's just
yeah.
not practical for us to prepare them. The second thing is that here in the States, we use Optisol to prepare our donor tissue or to store our donor tissue. In many places in Europe, they use organ culture. Organ culture is probably better. What do you use, Hosni? Do you use
It
Optisol?
depends, doctor. It depends, Dr. Jack. It's if you if it's, I think it's if it's like coming from the country, it's organic. I can't remember, but I think it's Optizol. I think it's Optizol still, to be honest.
Yeah.
I think it's Optizol.
Um,
Maybe
Probably
from
Optisol has
Italy, the one from Italy is
higher
different.
detachment rate. I don't
Yeah,
know, but
yeah,
probably it does. So I
yeah.
think if we really wanted to minimize our detachment rate, maybe organ culture would be better.
So yeah, so I will show you one video, if you don't mind, about preparing of a graft. That actually, if you do it very quick, I think this is one of the quickest one that we prepared. So it's different a little bit. When I went to the bank in Alabama, they do it in a very precise way, different. But this is actually the every surgery we do. So I just try to do some membrane blue. It just do it better, staining. And we start to score just underneath the Schwalbe line. I do the circular manner like this till I reach the point of start. Here it is. Then I keep just seeing that it's free 360. And I till I just check the point of the start again. And after that, I'll start to pull it. Just as a scuba technique underwater, pull it as flat as I can till it make a taco. Then this is the second part that I want to see. So usually when we reach this, we usually do a refined 3 millimeter here inside the cornea itself, the stroma. And after that, we unfold the graft back with jet of water, then flip the graft again on the top, remove the ones that have been refined, and do the mark and get it back and flip it back. So that take more time. And if in some centers you are going to have this kind of using the graft for two patients, one for DALK, one for DMEK, that won't work because you damage. So there's a nice technique I have started recently, that we start to do a bubble. So I put here inside this taco a small bubble, then I dry it well, and then start to put the F mark that we usually put. At this surgery, I didn't have an F mark. I used the Sansky to stain it and draw the F mark myself. Unfortunately, this video was decentered, so I will show in the other patient here how we stamp the F mark. Just here the F mark. We just draw it and put the F stamp here. And put the graft back with jets of water of BSS, and just iron the graft and let it be unfolded. And then we will put the Terifine over. So we do the Terifine in very gentle circular manner because we don't want to cut the whole thing. Or we can tap sometimes with the back of the forceps in a circular manner as well. And that's it. We remove it. And just like I don't want to waste your time, we just after that peel the one around and take
Yeah,
the graft and restain it. So yeah,
beautiful.
I agree completely. I did a small calculation before I do the video with you now. If Dr. Jack was doing his cases using this take in a good time 20 minutes, which is two grafts. You do the graft like the if it's like not very fast, 10 minutes. So each half an hour, instead of doing three grafts, you'll be the only one graft. So every hour we'll do two grafts instead of six grafts. So
Yeah.
it's a huge number. I understand.
Yeah. Well, it's so interesting because it's a tension that I feel all the time. When I visited Dr. Robert Osher once and watched him do cataract surgery, and a normal cataract surgery would take him 30 minutes. And he used to joke that he measures his surgical time not with a clock on the wall, but with the calendar on the wall. Okay. That's how he tracks his cases. Okay. And the way that he would do his cataract surgery is initially he would score a groove for his main wound using a diamond micrometer knife. So he would set the diamond knife to 300 microns and he would score a groove with the diamond micrometer knife. Then he would use a separate diamond mini crescent knife to tunnel up into the cornea. And then after tunneling up into the cornea, he would take a third knife, a keratome, and enter that tunnel and enter the anterior chamber. Okay. So you'd use three different knives to make the main wound. And this took 5 minutes. It took 5 minutes to make the main wound. And I remember thinking at the same, on the one hand, like, it can't take 5 minutes to make an incision. It's something that should take 5 seconds, not 5 minutes. On the other hand, his wounds look better than mine, So there is this tension between, do you want something to be as good as you can possibly make it, or do you want it to be done efficiently and quickly? And every once in a while, I feel like, well, it is important to know what is the very best possible way you could do things. And as you and I have talked about a million times, often that is also the fastest way. Often the fastest way is the best. But is it always the best? It may not be. And maybe preparing the grafts yourself, yeah, it takes longer, or maybe you need a team to do it and one person can't do it. It requires another doctor, but maybe it's the best. I genuinely don't know the answer. I really don't. If there's some production process, if there's some surgery, if a new surgery came out tomorrow that took 10 times longer than DMEK to do, but was better, I would do it. I would do it. Okay. I think that the best way to do something, that's the way I'm interested in doing it, the best way. But it's so difficult to know what that is sometimes.
Yeah, I agree, but I think this very nice surgeon, if I don't know how he managed with the team and the nurses, because here, if you do more disposables, I think they will hate you too much. But probably he's a very good manager to manage with this. I
Yeah.
won't be able to use all these tools. Yeah.
Yeah.
So just one more question, because I know, like, yeah, we exceeded the time and you are having a lot of patients waiting for you. Have you ever, in this kind of situation, like I have been in, because this came to my mind, but like that the devil was whispering in my hand, in my ear. So have you ever say, I will stop the surgery and refuse the graft and get another graft? Have you ever have this situation before?
Oh yeah, absolutely,
Really?
definitely.
Okay.
Not only me, but also at the Neos. I've been operating with Garrett, where they
Yeah.
have the eye bank upstairs. This graft is no good. Go get another one. Yeah,
Yeah, but
absolutely. Sometimes
if
it's the
it's if
graft's
it's like
fault, or it's your fault, and you've damaged the graft, and you need a new one.
and
Yeah,
for example, if it's very tight like this and it took a long time, so they can say, "Ah, come on, it's 49 years old, the graft, and the patient is very deep chamber. I took too much time. What time is it now? They have to call for other." Have you ever done that? Like you say, "Okay, I will terminate the thing."
absolutely. Yes, no
Okay,
doubt
that
about it. There have
you
been
make
some
me feel
times
better
where
now. Yeah.
I've got 10 patients on the schedule or 20 patients on the schedule, and I'm doing the first or the second case, and I
Yeah.
put a graft in and I can't unfold it, and I take it out and I throw it away, and I go get the tissue from the next patient, and I use that for this patient, and we
Yeah.
call the eye bank and say, send another graft.
Okay, that's Yeah, I think now you make me more comfortable that it's
Yeah.
but okay, of course, like maybe because we the graft here is not as in the States, like it take a lot of effort to get it, and we need to do a specific episode about the grafts and the very kind donors that give the graft for and share and making people see again and the process, which we need to talk about it later anyway. So, Dr. Jack, I don't want to increase more on you. Like it's already 40 minutes now. How time flies is like it's a good time flies very fast. So, I'm really looking forward to see you in 10 days. And in Cairo, in the Egyptian Society of Ophthalmology, which is one of the biggest in the Middle East conferences. And as much as I'm looking forward, I think 100 maybe thousand of doctors as well like are looking forward for this to see to see your presentation and learn as well as much as I learned from you. Yeah. So do you want to say something regarding for the people who are coming to watch you, what you are going to talk about, or like giving a teaser?
Well, it's just such a privilege to be invited. I can't wait. I've never been to Egypt before. I'm bringing my, Hosni, of course, I'm bringing my wife and one of my children. So we're all just so excited, so honored, and so ready to come. So we cannot wait to see you there at Hosni in 2 weeks.
I can't want to wait to see you again with Dr. Jack, and I assume we'll have a very good time, a great time there, and you probably will see a lot of Egypt and the real Egypt. Maybe if you come to London, I'll show you a little bit the Egyptian museum, but in Egypt it's different. Thank you very much, Dr.
Great.
Jack, and
Until
we
our
will meet
next
so
meeting,
soon,
Hosni. Yeah.
and probably we'll make another podcast in Cairo, hopefully.
Great. Yeah. Wonderful. Super.
Yeah, thank you very much. Take care. Thank you very much. See you. Mm.
You too, buddy.